Cerebral edema refers to the swelling of brain tissue due to an accumulation of fluid, which can significantly increase intracranial pressure, ICP. In patients with head injuries, cerebral edema is a common and potentially life-threatening complication that requires prompt diagnosis and management. Here's an overview. Types of cerebral edema. 1. Vasogenic edema. Disruption of the blood-brain barrier allows plasma and proteins to leak into the extracellular space, common in trauma, tumors, and infections. 2. Cytotoxic edema, cellular swelling due to failure of ATP-dependent ion pumps, often secondary to hypoxia, ischemia, or metabolic disturbances. 3. Interstitial edema, resulting from the movement of cerebrospinal fluid CSF into the extracellular space, typically seen in obstructive hydrocephalus. 4. Osmotic edema, caused by an osmotic imbalance, such as severe hyponatremia. Pathophysiology in head injury. Traumatic brain injuries, TBIs, often lead to vascular injury, hypoxia, and disruption of ionic homeostasis, resulting in both vasogenic and cytotoxic edema. Cerebral edema exacerbates ICP, reducing cerebral perfusion pressure, CPP, and causing ischemia. If untreated, it can lead to brain herniation and death. Clinical features. Symptoms include headache, nausea, vomiting, altered level of consciousness, focal neurological deficits, and signs of herniation, e.g. Cushing's triad, bradycardia, hypertension, and irregular respirations. Severe cases may present with coma or fixed dilated pupils. Diagnosis. 1. Imaging. CT scan, preferred in acute settings, shows hypodense areas indicative of edema and evidence of mass effect or midline shift. MRI, more sensitive for detecting specific types of edema, but less commonly used in emergencies. 2. Intracranial pressure monitoring. Invasive monitoring via intraventricular catheters or fiber optic probes may be necessary in severe cases. Management. 1. General measures. Maintain airway, breathing, and circulation, ABC. Elevate the head of the bed to 30 degrees to improve venous drainage. Avoid hypotension and hypoxia. Target CPP, 60 mg, and oxygen saturation, 94%. 2. Medical therapy. Osmotherapy, mannitol, reduces ICP by drawing water out of brain cells, requires monitoring of serum osmolality. Hypertonic saline, an alternative with similar efficacy. Sedation and analgesia, propofol or midazolam to reduce metabolic demand and ICP. Antipyretics prevent fever, which increases metabolic demand. Anticonvulsants for seizure prophylaxis, e.g. levetiracetam or phenytoin. Steroids, not recommended for cerebral edema due to trauma, but useful in vasogenic edema from tumors. 3. Advanced interventions. Decompressive craniectomy, surgical removal of part of the skull to relieve pressure in refractory cases. CSF drainage, via an external ventricular drain in cases of hydrocephalus or elevated ICP. Barbiturate coma, induced in extreme cases to reduce brain metabolic demand. 4. Supportive care. Tight glucose control to avoid hypo or hyperglycemia. Monitor and correct electrolytes, especially sodium. Prevent complications such as deep vein thrombosis, infections, and pressure sores. Prognosis. Prognosis depends on the severity of the edema, extent of brain injury, and timeliness of treatment. Rapid intervention improves outcomes, but severe cerebral edema with brain herniation carries a poor prognosis. Key points. Prompt recognition and aggressive management of cerebral edema are crucial in head injury patients to prevent secondary brain damage. The goal of therapy is to maintain adequate cerebral perfusion while minimizing ICP.